Hello, my name is Roxana Mehran from Icahn School of Medicine at Mount Sinai, and I'm really thrilled to be here and thank you for the invitation in delivering the anti-thrombotic therapy update, dual versus single antiplatelet therapy, triple versus dual. It is important for you to note my disclosures. I think what I'm going to do today in the next few minutes to talk to you about DAPT versus SAPT after PCI and triple versus dual therapy after PCI in patients with A-FIB. So over the last 40 years, we've been, it's been 40 years and plus after PCI, but after, really after stenting, there's a very, very important need for dual antiplatelet therapy. Early on, it was felt like it might have an important impact on neointimal hyperplasia, but we all know that the most important impact of antiplatelet therapies is in platelet and coagulation pathway activations that stents are responsible for, and the fact that there's blood flow reduction around the stent struts, and of course, thrombus formation, and hence dual antiplatelet therapy. And we also know that the more potent dual antiplatelet therapies are on there, we get a better efficacy in terms of reducing bleeding, but we will get more in terms of reducing ischemic events, but we will have more bleeding. The more potent it is, the more will be the bleeding. And in fact, there's been very good work done to compare the impact of bleeding and myocardial infarction on mortality. They're both really important. This is work from Marco Valgimigli showing that bleeding and MI, major bleeds, BARC3 and more, and myocardial infarction, spontaneous myocardial infarction, are both important. We can't ignore one for the other, especially if there's major BARC3C bleeds. It's even much, much more important than ischemic events. So very important to prevent these severe bleeding events. And furthermore, we are beginning to question the role of aspirin. There are important uncertainties around the use of aspirin. There are three major arguments that challenge the use of aspirin for secondary prevention. There's the bleeding risk. There is this very important question of risk reduction, that it could alter the baseline individual risk of cardiovascular events. And then, of course, now we have novel antithrombotics. So why would we need aspirin? And I think it's a really, really important one because with the potent agents, there's been very good work that shows that aspirin, in fact, might abolish or decrease the proposed antithrombotic effects of P2Y12 receptor blockade. This is an in vivo experiment. It's mediated by amplification of the antiplatelet effect of the inhibitory prostaglandins like PGI2. And in the presence of a P2Y12 receptor inhibitor, aspirin really provides very little to no benefit in additional inhibition of platelet aggregation. The STOP-DAPT2 investigators using the Zion stent looked at a 1-month dual antiplatelet therapy followed by clopidogrel monotherapy versus a 12 months dual antiplatelet therapy in patients undergoing PCI. And what they showed was a reduction of death, MI, stroke, as well as TIMI major minor bleeds at 1 year. So this was all mostly driven by reducing bleeding, no increase in ischemic events, so a very important benefit. The Smart Choice investigators did the same thing. 3 months versus 12 months, they showed a reduction in bleeding and no difference in their major adverse death, MI, and stroke at 12 months. Again, very, very important study that is telling us that a more novel way is to actually drop aspirin and keep with the P2Y12 inhibitors. The Global Leaders investigator did very, very similarly using an experimental arm of aspirin plus ticagrelor for just a month, followed by ticagrelor monotherapy for the next 23 months, a 2-year follow-up of close to 16,000 patients, ACS and stable. That's the experimental arm, with a control arm of aspirin ticagrelor for 12 months, then switch to aspirin monotherapy for the next 12, and then in stable CAD, clopidogrel for a year with aspirin, and then go into aspirin monotherapy. Here, their primary endpoint was to show a superiority in all-cause mortality and Q-wave MI. They just nearly missed that p-value, and to me, it's a very positive study. But unfortunately, it was a missed opportunity for this group because there was no central adjudication. The reference group had so many different comparators, but nonetheless, they showed actually a lower ischemic events. The bleeding doesn't look to be different, but that's probably because there was no central adjudication. In TWILIGHT, we actually had 9,000 patients enrolled in an open enrollment period with open use of aspirin ticagrelor. We then, at 3 months, evaluated these patients. 7,119 patients were randomized to ticagrelor plus aspirin versus ticagrelor plus placebo, and then followed for 1 full year. And what we found is that with aspirin ticagrelor, BARC 235 bleeding over that whole year was 7.1%. When you drop aspirin, you reduce that to 4% with the numbers needed to treat to reduce one of these events, but just 33 patients. Very important endpoint was this per protocol analysis looking at death, MI, and stroke. This was the key secondary endpoint, the safety endpoint. And take a look. Was there an increase in the ischemic events? And the answer is absolutely not. They were basically the same, and the P non-inferiority was met, so showing no change in ischemic events and a major reduction in bleeding. The TICO investigators did exactly the similar thing at the time of PCI, 3 months versus 12 months. The ticagrelor after 3 months was on just ticagrelor monotherapy. For patients with acute coronary syndromes, 3,056 patients, they showed an absolute risk reduction of 2% of the overall NACE outcome. And most of this was driven by reduction in bleeding. As you can see, the cerebrovascular events were absolutely no different. So it really is telling you that you can go to a single antiplatelet therapy in certain circumstances, and it works just fine. And if you really want to have that potent agent on board for a longer period of time, well, then drop the aspirin. Very interesting. Triple versus dual therapy after PCI is another story altogether. Patients with A-FIB absolutely we now need to think about stroke. They're at high risk for stroke, and stroke prevention needs an oral anticoagulant. Oral anticoagulants are a lot better for stroke and TIA prevention than dual antiplatelet therapies. This has been well documented in large AF studies. In PCI, on the other hand, though, oral anticoagulants don't work as well as dual antiplatelet therapies for stent thrombosis. So what you end up having is this needing for both of these treatments and a triple therapy that makes it really, really uncomfortable because there's a huge amount of bleeding. We talk about a dual pathway inhibition with the synergy of oral anticoagulants and antiplatelet therapies. If you think about those direct inhibitors of factor 2A, 10A, and antiplatelet agents such as aspirin and P2Y12, there is a synergistic effect targeting 2 essential components of thrombosis, coagulation and platelet activation. And we do know that when you combine these, triple therapy is associated with a huge hazard of bleeding down the line. The WOEST investigators, though, were smart enough to say, let's drop aspirin. In about 600 patients in a prospective randomized study, triple therapy versus dual therapy, and the dual therapy was an oral anticoagulant plus clopidogrel after PCI in patients with AF requiring an oral anticoagulation. They showed a major reduction in all bleeding endpoints. And although they were underpowered for mortality and the ischemic endpoints, they did not show a signal of harm. In fact, if anything, the dual therapy arm did better in terms of both mortality and ischemic events. It is for this reason that the European perspective comes together and really has a focused update on oral anticoagulant plus PCI. They basically say that if you're concerned about ischemic events and those are prevailing, that you should give 1 month of triple therapy, and then you can go up to 6 months, and then dual therapy beyond 6 months, and then oral anticoagulants alone after 12 months. just a dual therapy and do extremely well. The North American consensus also are kind of thinking about that. They're trying to come up with a pragmatic algorithm of AF patients requiring oral anticoagulants. You put the stent in, it's a high bleeding risk. You stop one of those antiplatelet regimens almost immediately. If there's a high stent thrombosis risk, you can keep going. If there's a high bleeding risk, you stop earlier. And here, the default strategy is really stopping the triple therapy after PCI within the first 7 days or so, and then going to a dual therapy up to 12 months. But when you're worried about high ischemic risk, you can go for a month of triple therapy. And I think that's a really, really important endpoint. The Augustus trial, amongst other trials, is the one trial that actually looked at the blinded withdrawal of aspirin in these patients. This was a 4,600 patients randomized to VKA versus apixaban, 5 milligrams BID, full stroke prevention dose. And then within there, a 2x2 factorial design of aspirin versus placebo in either one of those arms. A really, really well-conducted study. If you kind of look at this, you could see that in patients who received in blue apixaban, the event rates were much, much lower than the patients who received VKA in red. But apixaban with placebo down here did the best out of every one of those arms. And importantly, there was no issue in terms of bleeding, major bleeding significantly reduced, and no issue in the ischemic endpoints. In fact, apixaban plus placebo versus VKA plus aspirin gave a 5.5% absolute risk reduction with the numbers needed to treat of 18. There was an updated meta-analysis of all of these trials, putting together all of the evidence in PubMed, and this was done. And basically what you're seeing in JAHA, this was published in JAHA, and you can see here that the novel oral anticoagulant with a single antiplatelet regimen really, really did have the best possible result, and that it is no question that you reduce bleeding significantly, absolutely, all the way through, and you really are doing this in a very good way regardless. And if you take a look, bleeding, intracranial hemorrhage, clinically significant, major bleed, all in favor of going to a dual therapy, and the ischemic endpoints seem to be hugging the line of unity, with stent thrombosis with a little bit of a question mark regarding stent thrombosis. So I think what we could conclude for these patients in atrial fibrillation undergoing PCI, we've not found a difference in terms of MACE. Although we're seeing a little bit of an increase in stent thrombosis, we're underpowered to show that. And so those issues about stent thrombosis should be taken. And it maybe in those patients in whom you're worried about stent thrombosis, you can be a little bit longer with the aspirin. But really the default strategy could be a single antiplatelet regimen with novel oral anticoagulant. And after a certain amount of time, going to an oral anticoagulant alone, this will reduce relevant bleeding without increasing ischemic events. So less is more here, pretty much in every direction. I want to thank you for your attention, and thank you for wanting me to be here to give you an update on what's going on on DAPT and triple therapy in AF patients. Thank you again.